Have you ever encountered a teeth that looks slightly pink from within the crowns? Not on the surface. It is not due to stains, but a pink glow emerging from the inside of the tooth structure itself. This is not a cosmetic change. That is a pathological sign that indicates active internal or external reabsorption, and in classical dental terminology, it is known as pink tooth of mummery. In today's video, we'll go deep into this condition, understand it from a clinical, histological, and radiographical perspective. We will cover what exactly is a pink tooth and why it occurs, proper terminology and definition, histopathology behind the reabsorptive process, differences between the internal and external reabsorption, classic radiographical features, especially the ballooning effect, and finally, a step-by-step management strategy. This topic is extremely important for dental exams as well as clinical diagnosis because reabsorption is often silent until significant damage has occurred. Now, why does this teeth or tooth appear pink? This is the most important question before we begin. Now, a pink tooth appearance is due to the presence of a highly vascular granulation tissue present inside the teeth structure, usually replacing dentine. Now, under normal conditions, dentine is an avascular hard tissue that gives teeth their characteristic white yellow appearance. However, in pathological conditions such as reabsorption, this dentine is gradually destroyed and replaced by a soft connective tissue. This connective tissue is highly vascularized, rich in capillaries, containing inflammatory cells and elastic cells. Because enamel and remaining dentine becomes very thin, the underlying vascular tissue becomes visible through the tooth structure, producing a pink and reddish translucent appearance. So basically, in clinical terms, the pink color is not a stain. It is a blood-filled connective tissue visible through the thinning tooth structure due to internal destruction of dentine. So basically, this is due to the internal destruction of dentine, and this is a blood-filled connective tissue. Now, let's go to the next part. Let's learn about the terminology. Now, Pink Tooth of Mummery, named after James Howard Mummery in 1920. This is a descriptive clinical term used to describe the pink discoloration seen due to internal reabsorptive activity. It does not itself define the disease, but rather the appearance. Then we have the internal reabsorption when we have internal granuloma. Then we have odontoclastoma, which is a classic Schaefer term emphasizing the classic tumor-like nature of the reabsorptive process. Then we have the chronic perforating hyperplasia of the pulp and the pink spot, original term coined by Fothergill. Now let's learn about the histopathology. Now, before I go into this, we need to know that pink tooth is classically associated with internal reabsorption. However, advanced external reabsorption that perforates inward may sometimes show discoloration. Now, as we move into histology, we need to understand what happens at a microscopic level. Histologically, in reabsorptive lesions, we observe dentine reabsorption. Okay, we observe dentine reabsorption. So the normal dentine structure is progressively destroyed and it is replaced by reabsorption lacunae. Now these lacunae are irregular structures or irregular spaces created by what? Odontoclasts. Created by what? Odontoclasts. What is odontoclast? It is dentine resorption cells similar to osteoclasts. Okay, they're similar to osteoclasts, but they are not osteoclasts. They are dentine resolving cells. Now, then there is granulation tissue formation. So the reabsorbed area. Basically, what happens? First step we went to is dentine reabsorption. Correct? Second, we are going to talk about is the granulation tissue formation. In granulation tissue formation, basically the reabsorbed area is filled with highly vascular connective tissue, fibroblasts, and chronic inflammatory cells. What are the chronic inflammatory cells? We have lymphocytes, we have macrophages, and this is responsible for the tissue to appear pink in color. What this granulation tissue? This is responsible for the pink color. Okay. Then we have the clastic cell activity. What is the third one? Next one is the clastic cell activity. Basically, what happens is this multinucleated odontoclast-like cells, they attach to the dentine surface, okay, and they actively reabsorb the mineralized tissue, okay. They form this reabsorption base and irregular dentine destruction zones. Then the possible perforation. Next, we talk about the possible perforation. Okay. If the lesion is continuing without being checked, it may extend beyond the dentin. Okay. And it can perforate into the PDL and the periodontal ligament space. Okay. Leading to a combined endoperio lesions. So histologically, the key concept is that active odontoclastic destruction of dentine is replaced by vascular granulation tissue. Okay, so the granulomatous pulp, the tissue space is replaced by chronic inflammatory granulation tissue. This is basically the summary of what we discussed till now. Okay, the multinucleated giant cells, specifically termed as dentinoclast or odontoclast, which are histochemically and ultrastructurally similar to osteoclasts, which I have discussed earlier. Down, house-shaped lacunae. They're scalloped bay-like resorption defects carved into the dentin walls. And metaplasia. In some instances, the pulp may show metaplastic changes where the defect is partially repaired by osteoid-like tissue, bone-like material rather than dentine. So this is the diagram. We have the house shaped lacunae and we have the odontoclast here. Odontoclast, this is basically the odontoclast. You can see over here. Now, the next is what is the difference between internal reabsorption and external reabsorption? Now we have to clarify and clearly differentiate between these two conditions because this is a frequent exam question. Internal reabsorption. Where does the origin begin? It begins in the pulp canal or pulp canal wall, pulp chamber, or root canal. Okay. What is the pathogenesis? What is the pathogenesis of internal reabsorption? Basically, there's a damage, there's a damage or inflammation of the pulp. Okay. And this leads to clastic activity. Okay. Then this dentine is reabsorbed from inside outward. Okay. Radiographically, it looks like a symmetrical enlargement of the canal space, smooth round radiolucency with something known as a ballooning effect, which I'll be discussing next. Balloon-like effect. Okay, ballooning effect. Now, canal visibility. Canal outline is lost within the lesion. Okay, and the pulp is often vital at onset. Okay, now when we talk about external reabsorption, where does this begin? This begins at the start of the root surface, either cementum or PDL. Okay, what is the pathogenesis? Pathogenesis can be injury, trauma, orthodontic movement, and inflammation. Okay, what is the radiograph appearance? Okay, irregular, asymmetrical root moth-eaten shape. Okay, root surface appears eaten away. The key diagnostic features is that the root canal can still be traced through the lesion. Okay, and it's visible through the lesion. Okay, and the pulp status is it's often necrotic, if inflammatory. The golden difference we just need to know is that in internal reabsorption, the canal disappears, it blends with the lesion, whereas in external reabsorption, the canal remains visible through lesion. Okay? Now, radiographic features, the ballooning effect. This is the most important exam concept. Okay? And in internal reabsorption, the radiograph shows a well defined radiolucent area, a smooth symmetrical enlargement of the root canal space, uniform expansion of the dentine boundaries. Okay? This gives a balloon like appearance. Okay? Balloon being inflated in, inside the tooth. Why does this happen? Basically, the reason why this happens is because the reabsorption is centered. Okay, it is centered within the pulp canal. Okay, it can be that reason. It occurs evenly in all directions. Okay, and not irregular or surface based. So the canal expands uniformly, creating a balloon-like shape. Now, what is the external reabsorption contrast we see here? In external reabsorption, we see an irregular outline, jagged radiolucency, asymmetrical destruction. Correct? That's why we see it that way. Now, there's a uniform dilation. The canal appears balloon out into a smooth circular oval radiolucency. Canal show the shadow of the original root canal can be seen through the radiolucency. Okay, differential diagnosis must be distinguished from the external cervical reabsorption, shift shot, or the slob roll. So basically, in internal reabsorption, the the radiolucent lesion remains centered within the canal outline regardless of the horizontal angle of the X-ray tube. This is very important. What is it? Basically, the radiolucent lesion remains centered within the canal outline regardless of the horizontal angle of the X-ray tube. Now, what are the management strategies? Now, let's move into the clinical management. Okay, basically, in first step we do is if it is early detected. Okay, early detection. Let's talk about early detection. What do we do? The treatment is first we do is remove the inflamed pulp tissue. Okay, we complete RCT. Okay, complete root canal therapy, and through cleaning and shaping. The basic objective is to eliminate blood supply that is sustaining clastic activity because reabsorption is dependent on vital inflamed tissue. Okay. Now, the second step we are going to do, okay, the second step we are going to do is standard internal reabsorption management. Basically, what is it is after RCT, we do calcium hydroxide dressing. Okay, this helps arrest the clastic activity and disinfection of the canal system is critical. Then we obturate with the gutta percha. Okay, step three is the perforation case. So, if reabsorption has perforated the root structure, we basically do repair perforation using MTA. What is MTA? It's mineral trioxide aggregate. Okay, MTA provides excellent sealing and biocompatibility. Okay, followed by conventional obturation. Now, non-restorable cases. Okay, if destruction is severe, tooth becomes non-restorable, extraction is indicated, followed by prosthetic replacement options like implant or a bridge. Basically, we have to stop the pulp vitality. Okay, stop the resorption progression. Okay, now let's summarize everything. Okay, pink tooth is basically vascular granulation tissue visible to the dentine, most commonly due to internal reabsorption. Histology shows odontoclast and granulation tissue. Radiograph shows ballooning effect in internal reabsorption. External reabsorption shows irregular root surface loss, and treatment is mainly root canal therapy with or without MTA repair. So thank you all. So whenever you see a pink hue in a tooth, remember it is not a cosmetic anomaly. It is a sign of active internal destruction. Early diagnosis and timely endodontic intervention can save the tooth. I hope this session was helpful for you. I tried to make it as short as possible. And if you want a detailed session, please let me know in the comments. If you want any other topics to be covered, please let me know in the comments once again. I'm ready to help. Uh, if you, I hope this session was helpful and you guys enjoyed it. Please subscribe, and I hope I can help you with more contents. Follow me if you want to and learn about more dental topics and learn more NEET. I also focus on NEET as well, so you can subscribe to me for any cases. And I hope I was helpful for you. Please mail me or DM me if you have any doubts or queries, or you can comment down if you have any doubts. Thank you, and I hope I helped you all.